The panel is titled The IWOPS Journey and Beyond. So here we are at IWOPS 4, and I have several members here who are integrally involved with IWOPS 1, 2, and 3. And you'll notice that we're not doing any formal introductions at this meeting. We're all friends here. And if we're not friends, you will definitely be friends by the end of this meeting. But please join me in welcoming Dr. Carrie Reed from the US CDC, Dr. Daniella Paolotti from the ISI Foundation in Italy, Dr. Craig Dalton from University of Newcastle in Australia, and then Dr. Carl Koppeschar from the Netherlands. And I'm going to mispronounce this, but GroteGriepenCoronaMeting, or you have to correct the pronunciation for me.
Well, most people in English say Koppeschar.
Koppeschar.
It's Koppeschar.
Koppeschar. I'll try my best. Okay. So we'll follow the same format with the panel that you saw just before. We will ask our panelists a few questions, and really, we want to hear questions from you. This is an opportunity for you to ask our distinguished panelists questions. So let's get right to it. IWOPS 1 was held in 2012 in the United States, and one of the main goals was to explore the perception about the utility of self-reported influenza-like illness, ILI data. And so I'll start with you, Dr. Reed. Has the perception of the utility of self-reported ILI changed? And how does your team at the US CDC use this data for decision-making?
Yeah, so we were invited to the initial IWOPS really to talk about and to think about using it in a public health capacity at a public health agency, and have been engaged with the Boston Children's Group on Flu Near You and now Outbreaks Near Me for many years. And I think over that time there has been a growing appreciation for the value that getting this kind of information and engaging with the community to self-report information on influenza-like illness and also on their care-seeking behaviors and testing practices as a result of that illness can really add value to what we get from our traditional surveillance platforms that are usually based on healthcare-based information. So people who have sought medical care and been tested for influenza and who have been hospitalized or who've died, but that there's an added value from understanding what's going on in the community. And so we've used it in several different ways over the past several years. I think one of the early ways that we used it several years back now was during an influenza season where we had one state in particular who had noticed in their traditional surveillance data that an increase in hospitalizations and deaths that was unusual for them during their past flu seasons. It seemed inconsistent with the rest of the national surveillance data that was being shared in our weekly flu report, and so they were concerned that there was something unusual perhaps going on in the state, or were they seeing viruses that were somehow different and more severe than we were seeing elsewhere. And so one of the values that people saw of this data was to provide context to that traditional surveillance data. And so the question was, are we seeing similar trends in this participatory surveillance where people are self-reporting their experience of illness? Does it also seem to be increased, or are we seeing something unusual where the levels of illness are the same, but we're seeing more severe disease than we would expect to see? And so this data became one piece of comparing multiple different sources of surveillance information to see that we actually were seeing increased illness in the community based on this data, and that it was consistent and a consistent increase to what we were seeing in hospitalizations and deaths. And so there was obviously a need for the health department in that state to communicate that they were seeing a worse flu season, but it provided some level of reassurance that we weren't seeing something unusual about the virus that was more severe. And so I think people found that additional context to what we were seeing in surveillance was really valuable for the public health response. And then we've continued to engage with them and think about how to utilize this data in public health, especially during the recent pandemic response. We found the information from outbreaks near me to be really valuable in helping to understand what we were not seeing in our surveillance data. And so we all who work in public health know that what we see reported is often just the tip of the iceberg, right? That's a common metaphor. And so we wanted to understand what was happening that wasn't being captured in surveillance. How many people were becoming ill but not actually seeking out any sort of testing or medical care? How were people accessing testing and medical care? Had that changed from the way that people were accessing healthcare before? And so spent a lot of time going back and forth with the Outbreaks Near Me folks, thinking about what other questions might be important to collect to help understand what is happening, how people are reacting in response to illness. Are they accessing testing capabilities that were kind of increasing over the early part of the pandemic? What kinds of testing were they? Were they home testing? Were they testing at a testing center? Were they going to a traditional healthcare provider? And so that was able to provide us with increasing amount of context for what the epidemic was looking like that maybe was missed by our traditional surveillance systems. And then as things progressed and home testing became more and more accessible, we found the information from the system on how people were testing and why they were getting tested to be very important to understand the landscape of the public health response. There's a big emphasis on testing to treat once Paxlovid was available. And that was about the same time when home testing was much more available. And so using that information that we were getting on how people were accessing testing, if they were, what reasons they had for testing, was helpful to understand where there might be disparities in access to testing and access to treatment that could be factored into some of the decision and policy making around testing and treatment and reducing burden from severe disease.
Well, thank you. And so clearly, a lot of behavioral insights, it sounds like, and really how this data, you really highlighted on how this data can be used for a variety of reasons, whether it's policy or informing further research. So that aligns with moving on to IWOPS 2, which was held in 2013. And this meeting, amongst its other goals, focused on how data was being used from various systems. And it also resulted in a data sharing agreement between the three existing flu systems that came to that meeting, which is FluTracking in Australia, Flu Near You, which is now Outbreaks Near Me in the United States, and InfluenzaNet in Europe. And so my next question is for you, Carl. We're talking about data use, whether it's for decision making or research. But can you speak to the use of participatory surveillance to inform research questions and the creation of opportunities to engage communities beyond?
Yes. When we started in 2003 in the Netherlands, there was no surveillance systems else than general practitioners, but they kept the data for themselves. I'm not an MD, I'm an astronomer, but I'm interested in science communication. I was a science communicator in the Netherlands. So I thought of this system of participatory surveillance, and I wanted to give people the trust in a system, because we are not a government organization, that we are a private person, but we are really interested in the science of influenza. Because on TV, if there was an influenza wave coming up, you saw people sneezing, and say, oh, it's flu time. Well, people are not sneezing during flu time. It's just a common cold. So we clearly made some interesting questions and a whole questionnaire where we could divide between common cold, flu, and allergy. And I told them, you are yourself scientists because you are participating in this research. This is not a government surveillance. You are doing it yourself. And they were very interested. So it kept attention of Dutch Prime News on TV. And in an hour, we had 27,000 participants because they liked it so much, because the idea was new. Nowadays, we see a whole lot of participatory surveillances, and I'm very glad to see that, of course. And well, we continued with other questions because I noticed from other countries that flu is going like a wave through Europe. It starts either in Spain and Portugal or in England, and then it travels up north and then to the east. And it was like that during the big Spanish flu in 2018, 17 and 18. And it also traveled from Madrid to Russia in 3 months. So there was a kind of similarity. And I wanted to investigate if flu was really transmitted like that, because it is first the newborn are infected because they don't have any immune system yet. Then they pass it on to their brothers and sisters in school, and it spreads in school, and they take it to their parents, and the parents are commuting, and they take it to their work, and so it spread. It is a slow spread of the flu disease. So one of our IT persons, and he was going to do a PhD in Portugal. He took it to Portugal, and Portugal joined soon after in 2005. And then we got England and Italy in 2006. And independently, we learned about Craig Dalton, who also started it in 2006. And so then we had the idea for, well, we can build a complete international community later on with Flu Near You in 2012. And that's how it became to be. But I want to progress, really. But maybe I can talk about this later. This is just an overview.
All right, so moving on to IWOPS 3, which took place in Australia 3 years later, so 2016. And one of the focus areas of this meeting was really data sharing and privacy. And so my first question is for you, Craig. FluTracker has actually expanded beyond Australia. And so I'd really like you to comment on, what does it take to bring other countries on board to use a platform like FluTracker?
Yeah, look, I guess it's still an experiment in progress. We started 2006 in Australia and got huge increases during events like pandemics, of course. People get interested. And during this current pandemic, we had about 150,000 people per week at peak across Australia and New Zealand. And New Zealand came on in 2018. New Zealand is sometimes referred to as the seventh state of Australia, an extra state of Australia, and they're very similar. But we still have to make lots of adaptations for that country. But they very rapidly started getting 60,000, almost less than 10,000 to what we had weekly. So that's a country of about 4 million compared to a country of 26 million. So they very rapidly ramped up. We had to make some small changes. Even across the Tasman, they have different questions, different ways of recording educational status, employment status, health-seeking behaviour. So even there, we had to make changes. But I think I just did an analysis, did a calculation a little while back. Based on the population of New Zealand, if that was extrapolated to the US, they had an equivalent of 4 million people per week answering their survey at peak. So really amazing increase. I think, what does it take we're still learning what it takes, because in Australia we've done lots of experiments. And I think that's one thing, is you experiment, you have lucky accidents in what works. So finding champions who will promote joining and send an email that gets a few thousand people in one go. Or our chief medical officer during the pandemic made an appeal to Australians to join, and we had 20,000 people join that week. The clickable links in newsletters or newspapers that get people on. Then in 2020, Hong Kong joined. They have about 400 now, and Argentina joined this year. They have about 400. And growth has been slower there, and I think they're culturally quite different, so we're still learning what will work there. But I might stop there.
Thank you for sharing that. And Daniella, a related question for you as well. Your system engages multiple countries, and with 10 years of experience in participatory surveillance for ILI, what would you say are your biggest lessons learned?
Thank you so much, Nomita. And let me start by thanking you and Mark and the fantastic team at Ending Pandemics for organizing this amazing event and for inviting me to join this fantastic panel. So I like to use the word journey to describe the continuous learning process that these 14 years of participatory surveillance have represented for us. And Carl has given already a very nice overview of the beginnings. We got involved in participatory surveillance not so much from a public health perspective, but really from a very practical need as mathematical modelers to collect real-time data about episodes of influenza-like illness to feed our simulations, to feed our models. And we thought, well, if people don't go see a doctor for their symptoms, how do we know when and where the flu season will start? Well, let's go ask volunteers on the internet when they have symptoms. And we were inspired by the experience of the Netherlands, Belgium, and Portugal back in 2008 to really try and build a network of platforms. At that time, you still would use the word Web 2.0 to indicate platforms where the content was provided by users. And so we tried to really use technology to collect data directly from the general population to inform our models. And we really didn't know what to expect from these systems. The data were amazing. We could inform our models, but then the 2009 H1N1 pandemic hit. And this showed that these platforms could be used to unveil behaviors that could not be captured by traditional surveillance. For example, in the UK, the summer wave of H1N1 and the fall wave would show a completely different behavior in healthcare seeking. And people would go to see a doctor at the first sneeze during the first wave, and they wouldn't look for healthcare support during the second wave. And this showed a completely different behavior in how people approach healthcare. And so this was just the beginning of our learning process that is still ongoing. And during the past 10 years, we have learned that you can use these platforms to engage people in self-swabbing. So when self-swabbing was still unheard of in the UK there was a study that involved the participants from a flu survey to try and do self-swabbing at home, and now it has become really a regular thing that people do in their everyday life multiple times a day, or engaging specific population groups. For example, the French team engaged pregnant women to understand about their attitude toward vaccination, and so on and so forth. And then with the COVID-19 pandemic, the engagement has become really, really amazing. During the very first month, countries like Denmark or like the UK or France or even Italy have seen an enormous increase of people really willing to report their symptoms, because among the chaotic situation, they really wanted the public health authorities know about their illness. And now we are seeing how capturing behaviors like, for example, contacts or testing, or even the perception with respect to how dangerous this new coronavirus is, can really be game changers in the way you not only inform your models, but also how you inform public health decisions. And I think we still have a lot to learn and to discover how really the kind of data that we can collect thanks to the contribution of the population will contribute to future efforts. And in giving back the results of this data collection, you see people are really interested in seeing real-time maps, feedback about their own symptoms, what's happening around the area where they live. So this bilateral process of collecting data and giving back information is something that has been growing over the years, and that stimulates participation. And there's still lots of room to learn what we should continue giving back to people to really incentivize participation and collect more data.
Yeah, well, thank you for raising that, the possibilities with this approach in terms of what we can learn. And so I'm going to bring us back in the same direction. And Craig, many of these platforms, including yours, were being modified in real time to, help with detection and early detection capabilities during COVID. And so can you speak to just the realities of modifying a platform in real time during an outbreak or a pandemic, in our case, more recently?
Sure. So I should really acknowledge Sandra Carlson, who has to deal with the front line of these modifications, and any success we've had is really down to her careful and thoughtful and creative execution, and many hours spent dealing with the changes. I think one of the things to say about changing on the fly, and we've done a few, apart from COVID, we've also done thunderstorm asthma epidemics, which were set up over a couple of days. And, God, what was the other one we did? Oh, bushfire impacts. Had huge bushfires, you could see from outer space across southeastern Australia in 2019-20, having massive respiratory impacts, and we set that up fairly quickly too. I think one of the hardest challenges is getting the questions right very quickly and then testing them, and then running a small pilot quickly, a few thousand people, see what we get. And then often split testing the questions. So we do a lot of split testing to see what kind of answers we get depending on how we ask it. So that, I think they're the key things. And often it's about writing the questions out on a piece of paper, and we'll have a team meeting, and we'll say, okay, let's take these questions on paper to 3 people each in the building, and we'll meet back in an hour and compare notes on what worked. And then that's given us great insights, I think, on the fly to rapidly set up a new system and get it going quickly.
Yeah. Well, thank you. So we've talked a lot about the conversations really revolved around the use of participatory surveillance data. But what if we flip this question, Carl, and I'll pose it to you. How might research help advance the approach and the ways participatory surveillance is being executed? How can research inform this better?
Well, the original participatory surveillance is about sending out questionnaires and receiving data. And what we did right from the start was showing them real-time maps and graphs, and did the calculations like vaccine efficiency, and reporting that to the authorities because they took it also. I was most interested later on in the social aspect of pandemics and epidemics. And in 2013, I did a proposal to the European Union with Professor Jean-Pierre Alix of the Centre National de Recherche Scientifique in Paris. And we envisioned a system to be prepared for a pandemic and writing a kind of white book. What would happen? What would governments have to do when a pandemic would arrive? Unfortunately, it was turned down by the European Union. It only costed $4.3 million. That was the grant. And now it has costed 10,000-fold by all the countries finding out the wheel, discovering the wheel actually, what to do with the COVID pandemic. In that study, we would have had social scientists, political scientists, psychologists, economists, all kinds of other sciences than virology and medical sciences. Altogether, 19 institutions with 150 members also therein. It was turned down, unfortunately. But now I want to advance further. And during the COVID pandemic, we learned that a lot of people were socially involved because they were lonely. Schools were closed, bars were closed, restaurants were closed. In the beginning, we couldn't do any sports. Later on, golf. I'm a golfer. Hopefully, because they said, well, you're golfing in the open. As long as you don't communicate during your flight, it's okay. But so people were feeling really isolated. Students had suicidal ideation, and some even committed suicide. They were depressed, and there was a long educational attainment with a decreased earning potential, of course, because they couldn't study and it was all online and so. So the old-fashioned participatory surveillance, what we are doing still, that is the questionnaires on a weekly basis and with real-time results. But there is an important other aspect that is overseen by researchers. You can involve the participants to participate really. So not only sending out questionnaires and receiving it, but also involve them in doing the research and ask the researchers, why can't you study this? Because this is important in my environment or in my community. And we call that social join. We are experimenting now with this. And so we want to build a community of highly involved people so we can have questions about the environment, about social life, health, etc. And we have high hopes for that. We did a few small pilots, and that was very funny because the people involved were really enthusiastic, but the scientists didn't know what to do with it, the social scientists. That was a small pilot. And now we are going to start a larger one with 5,000 people in one particular city and try to make a whole digital community with the questionnaires, with them sending in their comments, and that all in a digital lab. And the first thing we want to do is loneliness, of course, social security, health, and environment. So it's really a kind of One Health.
Well, yeah, so I hear really expanding the directionality based on the expressed needs of the participants itself.
Yes.
It's really interesting. Thank you. And so before I open it up to the audience, so please jot down your questions, and the mics will be passed around. So be ready to shoot your hand up. Carrie, the last question from me is for you. Based on where you sit with the US CDC, how do you see better integration of participatory surveillance and traditional surveillance for today's threats and tomorrow's nightmares?
Yeah, I think kind of continuing on the path that we've been on and helping more people on the public health side recognize the value of this information in this community, and also the translation of that into public health action, I think is where this really needs to continue to improve. I think the example that I gave about the kind of evaluation of home testing and discrepancies and disparities in home testing, I think highlights ways that information from that can then be used to think about interventions in the community to decrease those disparities. And so I think the more people that become aware of this kind of information, how engaging with this participatory surveillance can provide information that can help then inform public health response, I think really is the future of integrating both the traditional surveillance platforms that we've used to kind of monitor the situation, but then also think about how this other source of information can help highlight the disparities that remain and therefore inform the interventions that can be done to reduce disease burden.
Great. Well, thank you for that. And so with that, I will open it up to the audience. So we have mics around. Please raise your hand if you have a question. Questions? I think the audience didn't have enough coffee. All right. All right.
Sure. Thank you. It's Mvuyo from South Africa. So one of the benefits of a participatory surveillance is the health-seeking data that we collect. So can you give us specific examples of how health-seeking data has been used in terms of planning and public health policy development? And for resource-limited countries such as South Africa and various other countries in Africa, how can we use this data to develop efficient strategies around resource allocation and improving the effectiveness of public health interventions?
Thank Thank you, Mvuyo, for this very important question. I would like to just mention the example during the pandemic, the summer of 2021, the French team GriepenCoronaMeting showed how basically all the surveillance systems in France were underreporting the number of cases of COVID-19 based on how many people would report their symptoms, their testing, and the rate of positivity. And this showed that basically the whole surveillance system in France, which is one of the really very good systems of surveillance in Europe, was consistently underreporting COVID even 1 year after the beginning of the pandemic. So this is just an example that shows how asking people, did you go visit a doctor for your symptoms, is one of the most important questions that we could ask our participants. And maybe the others want to report additional examples.
Look, I'd agree that the testing question was one of our most important questions, both in health sick going to a doctor or getting a lab test after seeing a doctor in the 2009 pandemic and this current pandemic. And it's a big leap to say what impact does that have on policy and interventions, but in terms of situational awareness, it can be a game changer. People are really surprised. And quite often what FluTracking does is tell the government that even though the laboratories are saying this is the worst outbreak of flu ever, it actually isn't, and or that the second wave of Omicron is actually worse than the first wave, even though the lab data says the opposite. So we need both, and I think the thing that the participatory surveillance does is give a really good reality check. It really gives us a really good check on aberrant behaviour of labs, of doctors, and of the general public. Stop there.
Yeah, well, the number of ILI patients in the Netherlands was always estimated as 600,000 by the general practitioners network. But using participatory surveillance, we noticed that in high flu season, we had 2.3 million people with flu-like symptoms. And that was adopted by the National Institute for Health and the Environment. They also mentioned, well, according to GPs, it's 600 or 630,000. But in reality, it is much more because the Great Influenza Surveillance reports 2.3 million people with flu-like symptoms. And the same applied to the COVID-19 because we are keeping track for people having COVID who tested and who did not do any home test. With the test, of course, it is, or with the health authorities, we know for sure that they had COVID, and we can deduce a vaccine efficiency for all the COVID vaccinations and boosters. For several groups, and especially for the elderly, 60, people with chronic diseases. And the funny thing, I didn't report it yet because we have these results in, and it's going to the National Institute for Health and the Environment. But it seems that the vaccinations were not that successful. We had the same experience with ILI vaccination for flu, because you have different strains of flu each year. And so the vaccine is always a little bit behind the reality because as soon the vaccine takes half a year to be produced by the vaccine factories. And also there we saw a low percentage of vaccine efficiency, about 20%, while the physicians, the GPs, always noticed about 70 to 90% to convince the population. And we saw the same actually with corona, with COVID. Also only for the 60 plus and the elderly with chronic diseases, it had some effect, but in the healthy population, it was very low. And it was, well, if you had a 95% confidence interval, it was somewhere about between 0 and 20%. And that's very funny because we had high hopes that the vaccination would help. But actually, I think that it's just the disease is passing away because of the herd community, more or less. And of course it helped. I had I've had 5 vaccinations, 2 original and 3 boosters. And so I feel healthy and I feel confident because, well, I don't see the necessity any longer to wear face masks. And, well. So
Okay, well, thank you. We'll pass it on to Carrie.
Yeah, thinking about the question around healthcare seeking behavior, I think one of the insights that we looked at that was maybe surprising for people in public health during the pandemic especially was that there were people who reported through this the system that they had sought medical care for their illness, but also said that they didn't get tested. And so there was a people were not getting captured because they didn't seek care in the first place, but also there were places that they went to where they didn't have access to getting tested. And so that was one piece of information that helped kind of, especially as home testing became more available, to think about how do we help people get diagnosed appropriately with the idea that that would improve infection control, but also improve access to then treatments. And on a flu side, there are antivirals for influenza that are most effective if they're taken very early on in the course of illness. But people often don't seek medical care fast enough to be able to receive those, or we can see in the data that people who seek outpatient care for influenza are very often not tested for influenza. And so I think understanding these behaviors of where people are most likely to seek care, how quickly they seek care, what forms of testing they seek out can really help identify where those gaps are, where we might be able to improve access to appropriate treatments.
Thank you. I did see a hand over here. Yes, please go ahead.
Good morning. Thank you for your very interesting talks. I have a question around the people who sign up to take part in this kind of participatory surveillance. So I can imagine, and I believe in Britain we have a similar app called Zoe, that during the pandemic saw a massive increase in people reporting. And I'm not sure now, but I can imagine that as the pandemic recedes a bit, the numbers may go down. So, and I heard Daniella talk about feeding into models. So I'm thinking, how do you overcome the bias that maybe the people who join up to report their symptoms, to talk about their behavior, are somehow different from those who don't, both in a pandemic situation and then in the in-between situation where, again, they may be different. And whether, in fact, that bias is important or whether it's not. Thank you.
Yeah, I'll just quickly say, because I think they have ideas as well. We have been working with the folks at Outbreaks Near Me to explore different ways of recruiting. And so Autumn can speak to this as well if you want to talk to her later about different ways that they've approached recruiting to look at both numbers of people that follow through and sign up, but also then consistency of reporting after the fact. And so I do think it's an important factor. We're looking at the data during the pandemic, and it does seem like we had a group of participants who were probably more health conscious and more mindful of kind of social behaviors and mitigation efforts, and maybe had a lower risk of illness than we were seeing in the broader population. And so I think getting a diverse group of participants with a wide variety of risk factors and behaviors would be useful. And thinking about ways to improve both recruitment and then retention of participants, I think, is an important question.
Well, we overcame any bias in the beginning by throwing away the first report. So when people were reporting ill, we said, okay, but if they stay long as a participant, then we trust them. So when they did it for half a year, we knew that that was a participant that was really interested and not just reporting in for fun. And we have a large cohort. They all reported in each year, each flu season. So we know about these participants. So there is no bias there. Only after 2017, I had to stop the surveillance because we were in financial needs. We are private persons organizing. We are not a government institution. Well, there was no money available, and I was in large debt because I paid it for myself, and I had to pay assistant editors, I had to pay IT specialists, and so on. So I stopped in 2017, and I was very sorry for that, because when the corona virus was circulating, we could have had it ready, and we could have tracked right from the start with the same cohort. With the same cohort of about 27,000 Dutch and Belgian people, and also from InfluenzaNet, because we were part of InfluenzaNet. We managed to start again with the help of other private persons. We are now a citizen science foundation, and we started again with flu and corona. It's called Flu and Corona Survey.nl, but then in Dutch, of course, you won't be able to pronounce it. And that's also more or less unbiased, because, as I told, we only agree with people who test it, really. So they can report in all the symptoms, and we keep track of that. We keep track of long COVID. We keep track of their vaccine efficiency. But especially when they were tested positive, we know, okay, this was a real a corona case. So that is unbiased. And there was an early publication in the Netherlands in 2006 about the population. And they compared it with asthma and other diseases, and it was exactly a copy of the Dutch population. It was, of course, only 27,000 on a population of 17 million, but we could check it with the other diseases and age groups, that it was a good sample of the Dutch population. But that was in Holland.
Greg, do you want to comment on how you ensure representativeness of your data?
Maybe how we strive for representativeness, but knowing they're very biased. You know, FluTrackers are probably the most intelligent people in the community, unfortunately. And in fact, we're trying to do an April 1st April Fool's Day promotion, but Sandra wouldn't let me do it, where we suggested that all FluTrackers, one of our biggest promotions is to ask them to invite 2 friends. If we ask them to invite 2 community-minded, big-hearted friends, they invite even more people. So we're going to ask them to invite their 2 dumbest friends with lowest IQ, but to help representativeness. But again, Sandra wouldn't let me do that, so we haven't done that. So when we look at the socio-economic status of the zip code or postcode of the participants, we see a big difference in the attack rate, how high the attack rate is, and how early the attack rate is quite often. So we actually, generously, CDC sent an EIS officer over looking at our data, and she's going to try and tackle that adjustment to see if we can adjust by socioeconomic status, either income, either education or zip code, to weight the data. For a lot, of course, for some questions it doesn't matter so much. So early on, Australia had really high COVID ascertainment. They predicted they're getting 85% of cases. But we knew among our high SES participants, only 60% were getting tested with pretty, a solid fever and cough. So we knew that estimate couldn't be right, because there's not that many people getting tested. So again, it comes back to the surveillance objective, whether the bias works for you or against you, I guess.
Yeah, and I just would like to add that the most intelligent people in the community are also those who participate in most European countries. Consistently over 10 years of data collection, we have seen that the highly educated people living in cities with no children and between 30 and 50 years old are the most frequent participants. But these are also the people who won't go see a doctor if they are ill, because they are healthy adults who probably wouldn't be concerned because of their symptoms. So we have to remember that we can correct for these biases. We now have so many years of data that we know how to correct for these biases in the models. And we also have to remember that participatory surveillance systems are not standalone systems. So they provide additional information and additional, let's say, picture of what this part of the population is doing in terms of symptoms or health or healthcare seeking behavior. And it has to be seen as really a fragment of a much broader approach and perspective that is overall health surveillance. So we shouldn't worry too much about the biases because we really want to capture that part of the population that is not captured by traditional surveillance. And even if it's biased, we know how to correct for these biases, and it's good information that can help take decisions.
Thank you. We have a question right at the back on the left.
Okay, it seems that it's me. I'm Pedro Saturno. I'm working in the National Institute of Public Health in Mexico. And I have a question that actually there are three questions interrelated. I was, for the first panel, I was about to ask them, but was no time. The question is, who took the initiative to implement all these nice programs, the ones that we heard before and these ones? It was a research initiative, it was an ONG, it was the government, any of them was the community itself? Is there a pattern for that? And the second question related to the first one is, do you think there is a best scenario for initiating this type of initiatives? It's better if it is the government, if it's a partnership between government and research, or what do you think? And the third, do you think that all these programs are sustainable without a decisive support from the government?
So I have a 6-minute warning, so I will let each of you give a brief answer and then I'll allow for closing remark.
Yeah, I'll be very quick. The beauty of this approach is that it can provide an answer to many different needs. So, for example, as I mentioned, we came from mathematical modelers' perspective, science communication needs, public health needs. So I guess that the flexibility of this approach is what really spurred the initiatives in various countries, more or less at the same time, and when technology was available. So the availability of technology really was the trigger.
I heard him mention, who was the driver? Was it an academic institution, or was it government or private sector or any sector? He's trying to understand, is there a pattern for success, or what tends to be the most likely?
We started in government, but in close collaboration with universities, and I think it's going to depend on the fit and the place and the culture. I think government is really essential to get the word out and promote it and support it, and to particularly have champions in government. I'll stop there.
Well, as I mentioned before, we are not a government organization. We were private persons, just scientists, interested in doing the surveillance. And I was a science communicator, a science journalist, and editor of a science publication paid by the government, but it had nothing to do with the government, only getting the grant. And people trusted us, therefore, because we always said we are privately privately researching this for your benefit, for your health, for your profit, for your health and well-being. And each time we said, okay, you are yourself scientist because you are participating in it. And with each publication, I mentioned also thanks to, with the line, thanks to so many thousand flu meters in Holland and Belgium and later on in InfluenzaNet. So that built a lot of trust in this community. And I think we need governmental organizations for the financial support and the sustainability. But should I have started as a medical scientist or for an institute or whatever, I don't think I would have had so many trusts in the population and have got so many participants.
Yeah, and then kind of similar to the other answers, FluNu originally was not started by the government. It was a Boston Children's Hospital, an academic institution that kind of spearheaded the development of that platform, and we got involved after the fact to think about how that might be useful to public health, and have continued over the years to work closely with them to think about what information to collect and how to use that in public health, and then also financial support over the years as well. And I do agree that kind of involvement of kind of the government public health groups, not just federal. FluNu and Outbreaks Near Me have had a number of state public health and local public health agencies that have found value in the data as well. And I think that is useful for it to be them to be at least one partner in these platforms to actually use it for public health decision making and public health interventions, in addition to the other benefits from the community and academic involvement as well.
So I'll let you hold on to that mic. And so my last question to each of you, in the last 4 minutes, I see Elizabeth looking at me, that we have is, when I think about the future of participatory surveillance, my mind starts to wander towards, wearables and forecasting and all of that. But really, from your perspective, what do you see as, when you look at the future of participatory surveillance?
I think a continued engagement with kind of all the partners involved to think about what is the most useful information to be getting out of the system. And so it could be contributing to initiatives like forecasting. There could be inputs from other things like wearables. But I think continually thinking about why the information that we're getting is important and how it can contribute to the evolving public health issues are really going to be central to the future of participatory surveillance, even if it in format is fairly similar to what it is now. I think the ability to continue to evolve and address the questions that really have a reason to then have a benefit from some kind of public health action and intervention associated with the information that's being collected.
Yeah, and I would really like to build a One Health system, a kind of disease radar, or more positively called a health radar, where people can check their health status and report everything. I planned that already in 2012, when we were having IWOPS 2 in Amsterdam. We were discussing that. Still was not able to perform that because of a lack of finances. But I think if we should all try, and if there is a support, we should build such a health radar, also to track pandemics, epidemics, environmental issues, animal zoonosis, etc. That would be a great thing for the World Health community.
Well, we're at the right place to start that here.
Yes, yeah, but now the financial needs, the grants.
I guess maintaining really high quality cohorts that can be turned on to any new disease rapidly. And at the moment, I think we've got 80% of our participants doing 90% of the surveys during our peak sort of winter period. So 60% will do 100% of the surveys during the peak 6 months. And some of them have been doing it for years. So having that cohort there that we can turn on rapidly to any new threat, and also knowing which ones we can ask, segmenting them by, I guess, almost like marketing personas, who we can use that we might ask to do virological testing and send the tests in, and getting that extra value from them.
And I can only second what Craig just said. So having loyal participants that can be longitudinally prompt for behavioral insights really represent an invaluable way of doing public health. So really the future of participatory surveillance is exactly what we are doing there, but with the long-term perspective and a sustainable approach. Yeah.
Excellent. Well, please join me in thanking the panelists. I know there were many hands up, so please, catch them during the breaks, but thank you very much for your comments. Thank you.